It gives me a great pleasure to introduce Professor Wijesinghe, Dean, Faculty of Medicine, and Professor of Medicine, KDU. Professor Wijesinghe was graduated from Faculty of Medicine, University of Rune, and obtained his MD in Medicine from University of Colombo, Postgraduate Institute of Medicine. And he completed his overseas training in New Zealand, where he obtained the fellowship of Royal Australian College of Physicians, and following advanced training in cardiology, he completed his training in intervention cardiology in St. Paul's Hospital, Vancouver, Canada, and he did the fellowship in intervention cardiology. He's a fellow of the Royal College of Physicians in Edinburgh, and the fellow of Sri Lankan College of Physicians, and a fellow of Cardiac Association of Australia and New Zealand. And Professor Wijesinghe is now currently the Dean of the Faculty of Medicine and Head of Cardiology Unit, University Hospital, KDU. So I warmly welcome you, and I invite you to start the sessions. Thank you.
Thank you, Ranga. Hope you all hear me. Okay, yeah. I'm always getting nervous when a good friend of mine give an introduction about me, because Surgeon Captain Ranga Pera knows too much about me, because we are very good friends. First of all, I thank the nursing department of the Allied Health Science faculty for inviting me to chair this session. I think this is the 6th consecutive session. I always enjoyed coming here and being with you during this session. Today we have 5 abstract presentations. When I went through that, I was very happy to see that we are getting abstracts submitted from various parts of the country, like previous years. This time also in this session, we have a couple from Sri Jawadhanapura University, and one from KAATSU International University, one from Ruhuna, my own faculty, and also one from our own KDU. So it's very encouraging and very interesting to see that the wide variety of submissions from various places. I hope next time we will get international submissions also. With the way our Allied Health Science faculty is progressing, I think we will be able to do that too. So we'll start our presentations. I hope all the presenters know that they have 20 minutes for the presentation. So try your best to stick to the given time, because you will be judged. And I hope that the sticking to the time limit also will be considered when giving marks to select the best presentation. So I want all the presenters to stick to the time, and followed by the presentation, there will be about 5 minutes for discussion. So if I invite all the audience as well as our online participants to ask questions, and the way they answer the questions also help us clear our doubts, as well as in order to give marks for to select the best presenter. So without spending a lot of time, I'll go to the first presentation today. The first paper is on a qualitative study of the perspective of care received by institutionalized elders in southern province Sri Lanka. And this will be presented by MLP Rasangi from the Department of Nursing, Faculty of Allied Health Sciences, University of Rune. The other authors are ADSS Karunanayake from the Allied Health Science Faculty, Rune, and KG Somasiri, Department of Physiology, Faculty of Medicine, Rune. He's one of the senior professors there, and actually one of my teachers. So very happy to see his name there. So over to you, Rasangi. Please start the presentation.
Good morning, sir, ma'am, and all of you. First of all, thank you very much, KDO, for giving me this opportunity. I'm Puputika Rasangi from Department of Nursing, University of Ruhuna. Before commencing, let me ask a small question. What do you think of population aging? Population aging is increasing exponentially day by day all over the world. According to World Health Organization, elderly population was over 1 billion by end of year 2021. So today I'm going to discuss few important things of our research study, a qualitative study of perspectives of care received by the institutionalized elders in Galle municipal area, Southern Province, Sri Lanka. Elderly has been defined as a chronological age 65 years old or older. As per the World Health Organization, population aging over 125 million, and it will be double from 12% to 22% by end of year 2050. As per demographers, population aging in Sri Lanka will be increased up to 21% by year of 2025. Currently, most of middle-aged and younger population in Sri Lankan society do engage with employments because of competitive lifestyle and higher cost of living. Therefore, most of them do not have adequate time to look after and spend and commit for their older parents. As a result, most of parents are institutionalized. The objective of our study was to explore the perspectives of care received by the institutionalized elders in Southern Province, Sri Lanka. Let's talk about the methodology. Qualitative phenomenological study design was used to conduct this study. On-site, semi-structured, face-to-face interviews that included open-ended questions were conducted to collect data. Interview guide was developed based on relevant literatures and it was pre-tested. We covered 4 areas in health, social, physical, psychological, and mental health. Institutionalized elders in Galle municipal area, Southern Province, was the study sample. Elderly people who were given written informed consent and who were potential for the interview were included for our study, and those who were not excluded from the study. Semi-structured face-to-face interviews were conducted by the principal investigator at each elderly care institution. Each interview was audio taped and then transcribed verbatim. In here, we allowed adequate time for all interviewees to express their ideas freely and truly. And also, their dignity and their confidentiality and their identification were preserved during the interview time. Data collection was done until data saturation point achieved. Thematic analysis was employed for qualitative data analysis, which consists of 6 phases, including familiarization of data, searching for codes, searching for themes among codes, defining and naming themes, reviewing themes, and finally producing the final report. The ethical approval was granted by the Ethical Review Committee, Faculty of Medicine, University of Ruhuna. Let's talk about results. This is the sample characteristics of our study sample. 50 elderly individuals participated for the study. Majority were females. When considering ethnicity and religion, majority were Sinhalese and Buddhist. From this, we can see where we are in the society and how we look after our older parents. These are the themes and sub-themes emerged based on thematic analysis. We emerged 3 main themes and sub-themes according to that. The first theme is enhanced physical health, which includes 3 sub-themes: relieving generalized body pain, care for visual and hearing impairments, care for chronic disease conditions. The second theme is concern for psychological and emotional status, with 3 sub-themes including care for anxiety, lack of companionship and social interactions, and feeling of hopelessness. The third theme is enhanced spiritual well-being, with 4 sub-themes: improving spiritual health, promoting recreational and aesthetic activities, limitation for outside traveling, and paucity of celebration special events. Let's talk about themes and sub-themes one by one. The first theme is enhanced physical health. The perspectives for physical care were often taken by elderly individuals: relieving generalized body pain, joint pain, back pain, muscle pain, and muscle cramps were more common among elderly persons. Mainly joint pain and back pain were common among female individuals with compared to male individuals, but they didn't take any proper treatment. They have taken some local appliances like Siddhalep and some home remedies. And also there were no one to pay attention for these minor conditions. Care for visual and hearing impairments. Poor distance and near vision were common among both male and female individuals. They were unable to perform their day-to-day activities because of poor vision. Most of were wearing spectacles that were received from government mobile clinics or any donations. And also, hearing impairments, hearing loss were common among them, but few of them were wearing hearing aids. Care for chronic disease conditions. Hypertension, diabetes mellitus were most common among both males and females. In here, they all were taking proper treatments and regular follow-up clinic visits from clinics in government hospitals. The second theme is concern for psychological and emotional status. Elderly individuals were living with several psychological and emotional issues. These psychological conditions were significantly common among female individuals. The care for anxiety. Separation from the family was a major psychological issue among them. They were separated from their family, their children, or their siblings. Lack of companionship and social interactions. Lack of companionship and social interaction were also common among elderly individuals. Peer companionship was more reduced among female individuals when comparatively male individuals. We noticed that most of male individuals were singing and doing several group activities as a group, but we didn't notice that kind of thing among female individuals. Most of the time, they were looking far away and thinking alone. Feeling hopelessness. Most of elderly individuals were institutionalized due to nobody to care for them. Married inmates were rejected by their children, and unmarried were rejected from their siblings and family. They do not have do anything. Finally, they institutionalized because they have nobody to care for them. Enhanced spiritual well-being. Enhancing spiritual health is a crucial element in elderly persons, especially under institutionalized care. Institutions provided various facilities and a separate place for religious activities to celebrate religious festivals and also cultural events. Promoting recreational and aesthetic activities, all elderly individual institutions has offered several staff to spend their leisure time. Limitation for outside traveling. Most of elderly individuals said that they are looking forward to go outside and enjoy someday, but institutional authorities didn't allow such kind of outside travelings. Positive celebrating special events. Celebration of special life events such as birthday was not encouraged by the institution, but they told with us that if they receive this kind of opportunity, actually they will be happy. This is a small comparison between our current study with other studies. In conclusion, the results presented study that physical, psychological, and social and spiritual care domains have a greater impact on care received by the elderly in order to improve their quality of life. These are few references, and thank you very much for your attention.
Thank you, Rasangi, for your timely and very important topic selected for this presentation. Now the paper is open for discussion. I invite all of you to ask questions and clear your doubts. That includes the students also can ask questions. Please do.
Can you tell us why you selected the phenomenology as your methodology?
Phenomenological study is a good method to evaluate one's experiences and feelings. In here, we mainly focused on their ideas and perspectives. That's the reason we selected phenomenological study, ma'am.
Thank you. So, when you use qualitative research approaches, usually we go for less number of participants. So I noted that you have done interviews with 22 male residents and 28 female residents. So what is the reason for go for high numbers, especially when it comes to phenomenological studies? They recommend that low participants but in-depth interviews. So can you explain why?
Madam, even though it's recommended low participants, we had to conduct interviews until data saturation point achieved. That's the only reason. Yeah, 15.
Okay, one last question.
One thing, when you are doing these phenomenological studies, don't you think if you have done a better way, if you had a better questionnaire and quantify your findings in numbers, that will be more scientific and more, acceptable to the scientific society if you done in a qualitative and a quantitative study. That's what I feel like, rather than going to small number of individuals and adding individual, if we go to institute and ask what are their problems, there is sampling method, they will give the most problematic person then for you to ask questions, and you are going in depth on that person and you will not get the actual setup. That's one thing. I think you could have gone for a quantitative study and a qualitative plus a quantitative one where you can do a statistical significant, and there are enough questionnaires to assess the quality of life in elderly. So you could have got one of those qualitative assessments and compare with numbers. That is more scientific. That's one. I think it's what you mentioned about WHO classification of elderly 65. I think they have changed now. So it's still 65. Okay, right.
Okay, yeah. One last comment from me is that I hope the exclusion criteria you mentioned, psychological, physical and psychological abnormalities as exclusion criteria. So I hope what you all meant there was the cognitive factor as well, because some people in the elderly care institutions may be having some amount of dementia. So that might affect the affect their responses to your questions. So the psychological dementia may not be straightforward psychological problem. It is a separate neuropsychiatric disorder. So, I think what you meant from there is dementia as well.
Yeah.
Right? Okay. Okay. Thank you so much, Rasangi, for your presentation. It's a very timely and important because the elderly population is growing, and the rate that our Sri Lankans are migrating, the elderly patients will be left alone, right? And in years to come, there will be many more, including us, when we get old, will be institutionalized like this. So thank you very much.
Thank you very much, sir. And thank you very much all.
Let's move on to the next presentation. That is on knowledge towards sexually transmitted diseases among undergraduates of KAATSU International University, Sri Lanka, a cross-sectional study. The presenter will be MFF Fasmila from the Department of Biomedical Sciences of the Faculty of Health Sciences of KIU. The other authors are MGPA Gunarathne, WLM Alwis, MSF Minnath, RMS Fernando, VDR Tharindu, MKA Sampath, and KMHH Kulathunga. Over to you, Fasmila.
Thank you so much. A very good morning to dear ladies and gentlemen. I am Fasmila. I am from KAATSU International University, Battaramulla, Sri Lanka, and my paper ID is 256, and my research topic is knowledge towards sexually transmitted diseases among undergraduates of KAATSU International University, Sri Lanka. These are the contents of today's my oral presentation. To give a brief introduction about my research topic, I would like to explain about sexually transmitted diseases. So, STDs are defined as bacterial, viral, or parasitic infections predominantly transmitted through sexual activities. However, HPV and herpes can be transmitted through skin-to-skin contact as well. There are more than 35 infectious organisms involved in STDs. And also, STDs can be transmitted from mother to child during pregnancy, childbirth, and breastfeeding. When it comes to STD patients, they may experience abnormal vaginal discharge, urethral discharge, or burning sensation, etc. When it comes to STDs, majority of STDs are asymptomatic or can cause mild symptoms. STDs are major health issues worldwide. So more than 1 million sexually transmitted diseases are acquired every day worldwide. Also, more than 1 million deaths have been reported worldwide annually. When it comes to Sri Lanka, National STD AIDS Unit reported that more than 100,000 patients get treatment from STD clinics annually. The approach to the research question. First, I would like to say that lack of knowledge about STDs and their symptoms in society. To support this, I would like to say through literature review, we found out that majority of the people don't know about other STDs than HIV/AIDS. And also, majority of the population don't know about the curable STDs in the society. Most importantly, the drugs which are used to treat STDs are developing resistant to the drugs. So due to poor awareness regarding the STDs, it can cause a major problem. Also, when it comes to the level of knowledge, there can be difference between socio-demographic factors such as age, gender, religion, etc. And also, sexual transmitted diseases that can easily access to sexual intercourse and multiple partners. The adolescents are vulnerable to sexual risk because they can undergo rapid cognitive, behavioral, emotional, and social development. Therefore, we have chosen our study population as undergraduates of KIU because they are adolescents and they can undergo different social, emotional, and behavioral developments. This study was conducted to assess the level of knowledge regarding STDs among undergraduates of KIU Sri Lanka. When it comes to the methodology of our research study, it is a cross-sectional descriptive study which was done using enrolling 390 participants from all the faculties at KIU Sri Lanka. And our study sampling method was convenient sampling. When it comes to data analysis, we used SPSS version 25.0 software. We used Bloom's cutoff point to evaluate overall knowledge assessment. According to Bloom's cutoff point, between 106 to 154 indicated as good level of knowledge, whereas between 90 to 106 indicated as moderate level of knowledge, and also below 90 marks was indicated as poor level of knowledge. When it comes to the association between demographic characteristic and the level of knowledge, all the assessed data were used by chi-square test by using SPSS software. As you can see in the table, all the p-values are less than 0.05. That indicates that all the assessed socio-demographic factors has the significant association between the level of knowledge in our study. When it comes to the results, as you can see in this table, in our study, majority were females who were between 21 to 25 age category, and they were from mixed school and did bioscience for their A-levels, and they were majority were Buddhists, and currently they were from Faculty of Health Science in the 4th year. So level of knowledge on STDs, this left side chart it's showing that majority of the participants had good level of knowledge, and only 125 participants had poor level of knowledge, and the moderate level of knowledge had shown like 132. And when it comes to the right side chart in this slide, you can see that is frequencies of choosing non-STDs from the given list. As you can see that 89.5% of participants had chosen HIV AIDS as most non-STDs from the given list, followed by gonorrhea, syphilis, herpes, genital warts, etc. When it comes to gender-wise distribution of knowledge level on STDs, 24% of male had good level of knowledge, whereas 39% of female had good level of knowledge regarding STDs. When it comes to the moderate level, females had shown 28% and males showed 46%. And also, when it comes to poor level of knowledge, males showed 30%, whereas females showed 33% in our study. And also a study showed that the study indicates that school, internet, and social media played major role as the source of knowledge about STDs in our study. Also, we had question choices of participant on signs of STDs, but majority of the participants had chosen that painful ulcers are the commonest signs of STDs in our study. When it comes to analysis of knowledge level among Faculty of Health Science and non-health science undergraduates of KIU, most of the health science students had good level of knowledge, but non-health science students had moderate level of knowledge. So as the conclusion, I would like to say that the present study showed the critical features of information about the knowledge of KIU undergraduates with respect to sexually transmitted diseases. So overall, the undergraduate population of KIU had a moderate level of knowledge regarding STDs. But gender-wise, female had a good level of knowledge, whereas males were projecting moderate level of knowledge. According to faculty-wise, I could say that Faculty of Health Science undergraduate showed good level of knowledge, whereas non-health science faculty showed moderate level of knowledge. And statistically significant association was observed between all the assessed socio-demographic factors, such as gender, faculty of studies, age, marital status, accommodation method, type of school attended, and academic year, also employment status. This study was funded by KIU, Vattaramulla, Sri Lanka, and these are the references I used for this oral presentation. That brings me to the end of my presentation. Thank you so much for listening.
Thank you, Fasmila, for your presentation. Now, paper is now open for discussion. I have a question. Now, you selected 390 participants from 3,080 population. What was the method used to select them?
Thank you so much for your question, sir. We use convenient sampling method.
Yeah. Now, this population had like out of 390, majority were females.
Yes.
Do you know the male-female ratio of that original population?
No, sir.
Yeah. Now, that is why I say is now, if you want to generalize your findings to at least into the KAATSU University, then the sampling method should be that, if there are 60% females and 40% females in your selected sample also, out of the females, you have to select the same proportion, and out of the males, that is actually stratified sampling. You have to do a stratified sampling, then it represents more that of that population. Any other question? Yeah.
I think it is not that good because
Because it's a learning
readers get
exercise. Shall we go
confused.
to that? Because there are students also, they are also preparing. I mean, these are all learning exercises. That is why I normally tell in other instances also, we criticize, we comment on things for us to improve. And we all are learning, right?
Yeah.
So if you can go to that, what Dr. Kalpani is pointing out is a very important thing. Yeah, you go ahead. Now that yellow color in the female chart is moderate. In the other side, it was poor.
Yes.
So because if you select the yellow for the poor, green for the same color for in both charts, that would be like, people can understand it easily.
Yes.
Yeah, I think it's a very good point that you. Any other question?
Thank you.
And I think in your diseases list, you have put tuberculosis as the list of diseases.
That I think they want to
Compare.
identify.
Yeah.
You should identify that.
Yeah.
You should have mentioned that in your
Yeah.
presentation. You have
Yeah.
put tuberculosis to identify whether they know it.
And one last comment from the abstract. It was not mentioned there. It says unprotected sex is a growing trend and awareness must be increased. Do you have any data to substantiate that statement? I didn't know that. Unprotected sex is a growing trend.
Through literature review, we found out that.
So compared to previous decades, suppose like when we were young, now the people are practicing more unprotected sex than before, is it?
Yeah.
Okay. All right. Thank you, Fasmila. Thank you for your presentation. We'll go to the next topic, which is on knowledge towards and practices on first aid and cardiopulmonary resuscitation following road traffic injury among traffic police officers in selected police divisions in Colombo district, Sri Lanka. This will be presented by TMHS Amaratunge from the Department of Nursing and Midwifery from University of Sri Jayawardenepura. The other author is AATD Amarasekara. So over to you, Mr. Amaratunge.
Thank you very much, sir. I wish you a very good morning to all of you. First of all, thank you very much for giving me this precious opportunity. So today my presentation is on knowledge towards and practices on first aid and cardiopulmonary resuscitation following road traffic injury among traffic police officers in selected police divisions in Colombo district, Sri Lanka. These are the contents that I'm going to talk about in next few slides of my presentations. Moving on to the introduction and literature review. Road traffic accidents has become an increasingly significant public health issue worldwide, accounting for up to 60% of the global disease burden. In Sri Lanka, road traffic accidents has been ranked 10th in the top 50 causes of death, which is exactly, we cannot underestimate the number. Most of the deaths occur in pre-hospital phase in low and middle income countries. According to the WHO, inadequate post-crash care has become one of the main reasons to increase in the severity of injuries in an RTI. Traffic police officers can play an essential role in providing care for these victims in an RTI because they are the first responders in RTI as they are often performing their duties on roads, and also they are given first aid and CPR training during their tenure. Though several studies had been conducted on the same topic in both global and Sri Lankan contexts, the studies conducted among traffic police officers were limited to a very few. So this is the objective of my research study, to examine the knowledge towards and practices of first aid and CPR following RTI among traffic police officers in selected police divisions in Colombo district, Sri Lanka. Talking about the methodology, in Colombo district, there are 6 police divisions, namely Colombo North, Colombo South, Colombo Central, Nugegoda, Mount Lavinia, and Calinia, out of which 3 police divisions were selected randomly for this study. They are Colombo Central, Colombo North, and Nugegoda. So my study design was a quantitative descriptive cross-sectional study. Study population was traffic police officers who were working in Colombo district. Into my inclusion criteria, I included traffic police officers who were currently working in Colombo district with at least 1 year of work experience. Exclusion criteria was traffic police officers with less than 1 year of experience who were working in Colombo district. So my total sample size was 148. So this is the breakdown of my total sample into police divisions and police stations. So, sampling technique, 3 police divisions were selected randomly in Colombo district, out of which 10 police stations were again selected randomly. Then the proportion of number of police stations was calculated according to the number of police officers working in each of these randomly selected divisions. Traffic police officers required for this study were selected conveniently from each police station. Just from you all for the inconvenience caused. So moving on to the results, I have shown some social demographic characteristics among my sample size. So first, you can see the gender. The vast majority of the sample was males, accounting for 95% of the total sample number. And the ethnicity, again, the majority was Sinhalese. Only 1% of them were Tamil. Talking about age group, a majority of them belonged to the age group of 21 to 30 years. And more than half of them have a first aid training during their tenure. And below, I have shown their monthly income, work experience, and the education level, how they have distributed among the sample. So the knowledge on first aid and CPR, the majority of the respondents had a good level of knowledge on first aid and CPR, while only 31% of the respondents had an excellent knowledge. Here I have mentioned some key areas that I noticed in the sample that they had a very good, good level of knowledge and poor level of knowledge. So majority had a very good knowledge on identifying signs of bleeding, easiest site for detection of pulse, and normal pulse rate of a healthy adult. In contrast, a majority had a poor knowledge on importance of the golden hour, the landmark for chest compressions, and the chest compression being a component of CPR. Talking about the practice of first aid and CPR, almost all the participants have witnessed an RTA during their tenure. Among them, 72% of the participants have claimed that they have assisted a victim on an RTA. Only 2 participants claim otherwise. No one was able to score more than 75%. Thus, no one had an excellent level of practice. More than 90% of the participants had a poor level of practice. Only 20 participants had carried a first aid kit with him or her on the field. So according to the results, these are the conclusions that I could make. First one, the majority of the participants had a good level of knowledge. However, deficient knowledge was observed in some fundamentals areas, such as the importance of the golden hour and the landmark for chest compressions. Level of practice was significantly unsatisfactory on performing first aid and CPR. So my recommendations are, it is recommended to conduct comprehensive training and refresher courses by the police authoritative contacting healthcare professionals at least once in 3 months in order to improve practical skills of the traffic police officers towards performing first aid and CPR for victims in an RTI. Additionally, it is recommended to allocate a sufficient number of women police constables as they could contribute more on providing first aid and CPR for female victims in an RTI. Furthermore, implementing a process to assess knowledge and skills on first aid and CPR among traffic police officers on a regular basis is recommended. So these are the references I used for my study. And I would like to convey my sincere gratitude to all the study participants and everyone who supported throughout this study to make this a success. And that is the end of my presentation. Thank you very much for your attention.
Thank you, Mr. Amaratunge. Thank you for your presentation. And the paper is now open for discussion. Now, how did you assess the practice?
Sir, I assessed the practice as a self-reported practice. I used a self-administered questionnaire for that.
You know, I mean, practice is some assessment of skills, which you can't do by giving a questionnaire. I mean, I can be always assess the skills, knowledge by giving a question paper, but skill assessment cannot be done. For that, you know, you have to give at least a mannequin and get them to do cardiac compressions and give a ambu bag or something to give some artificial breathing and something like that, and also give shocks whenever possible. So that is one of the major deficiencies I identified. Secondly, how did you select the sample?
The police divisions were selected randomly, and the police
You
station.
selected 3 divisions.
Yes, 3 divisions, and in that 3 divisions, I took 10 police stations that was also selected randomly, and in that 10 police stations, I selected traffic police officers in using convenient method.
Yeah. So again, you need to know how many male and female traffic police officers are there. And when you select some important study like this, you have to always apply the stratified sampling methods. And the last thing is, now your recommendation is to increase the number of female police officers to give CPR for female victims, which is not necessary. Because when in an event of a cardiac arrest, we don't care where the victim is a male or a female, we just give cardiac massage. Because the primary reason for allocating a traffic police officer is not to give cardiac massage or CPR, that is to do their duty. So, I mean, we work as doctors, there are nurses here, and we don't care. There's nothing in the practice that we do CPR only on our own gender. So that is not a requirement. I don't think that should be a recommendation. Anything else?
I'm sorry, I don't exactly remember the names of the authors, but I think I have mentioned it in my extended abstract. But I'm sorry, I can't remember the names.
You have taken a self-administrator, so you said you have prepared the questionnaire with your supervisor. So
yes.
You cannot. So if you have to use the same questionnaire, any criteria, but if you are using a criteria, so you validate it and you have to draw ROC curve to do that, right? So I think that would be a suggestion for your next exam. If you criteria, so you have to make the levels. Otherwise, you have to take the same question.
Right. Okay. Thank you very much for your opinion.
Okay. Sorry. Go ahead.
You say here that you have assessed first aid plus CPR.
Yes.
But I think your questionnaire does not include separate questions to assess first aid as well as CPR. So therefore, my view is like your title is little bit misleading the reader. So be careful when you write the titles and include the information in the abstracts like this. So it will like begging for unnecessary questions and misleading the readers, and it is not a good practice in the research publication. It's kind of fabrication.
Yes, madam. Okay, thank you very much.
If you can change this as assessment of the knowledge, is I think I was supervising one of the, few years ago, you were there, right? He was my other co-supervisor. We did something similar using the Nugegoda and Manupulania police divisions. We took about more than 200 police officers, and also we went and did training sessions for them. In the Mirihana police station, we did the training session. It was very interesting. We went with our students and but we could not actually assess the skills because we have to test it. Okay. Thank you very much.
Okay,
It was
thank you very much,
very
everyone.
important topic. Excellent.
Okay, thank you
Yeah.
very much.
Keep doing it. The next topic is the attitude towards and willingness to work with older people among nurses at University Hospital Kotelawala Defence University, UHKDU, Sri Lanka. The presenter is R.T. Balachandra. Other authors are R.A.P. Hansamali, S.M. Dahanayaka, W.P.I.P. Premarathne, H.S.M.S.K. Wijesinghe, S. Ratnayaka. They are from the Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Surgeon, Kotelawala Defence University.
Thank you, sir. Good morning. I'm R.T. Balachandra, the presenting author under paper ID 440. Our topic is the attitudes toward and willingness to work with older people among nurses at University Hospital, Defence University, Sri Lanka. So according to my today's presentation, these are my main content areas: introduction, objectives, methodology, results, conclusion. So introduction, what is aging? According to the WHO, biological aging results from the impact of an accumulation of a wide variety of molecular and cellular damage over time. So the age of 60 is the cutoff point to define an older person in Sri Lanka, according to the Department of Census and Statistics in Sri Lanka. But when we take it as globally, it's age 65, according to the WHO. So there, as we all know, there is a age growing in all the population, both Sri Lanka and also globally. So there's an increasing need for nurses with positive attitudes and willingness to work with older people. So according to my research, these are my objectives: to assess the attitudes toward older people among nurses in UHKDU, Sri Lanka, to identify the willingness to work with older people among nurses at UHKDU, Sri Lanka, to examine the association between socio-demographic variables with nurses' attitudes toward older people at UHKDU, to examine the association between socio-demographic variables with willingness to work with older people at UHKDU, Sri Lanka. So the methodology, research design, setting, and sample. It was a descriptive cross-sectional study conducted among all the working nurses in UHKDU at that time. So UHKDU was comprised of emergency and trauma care units, general medical and surgical units, pediatric units, and obstetric and gynecology units. So in that time, there were 304 working nursing officers in UHKDU Verahara. So as I mentioned, our inclusion criteria is all the nurses who are working in UHKDU, and also we had exclusion criteria. The nurses who were not willing to participate, and the nurses who are on their maternity leave, and the nurses who are on their vacation. So the instruments, First, we used a self-administered questionnaire, including socio-demographic variables. There were 7 variables. We assessed age, gender, level of education, residence type, working experience, family structure, and total family income. Then, to assess their attitudes, we used the Coggan's attitudes toward older people scale. It consists of 34 questions, and there were 17 positive and negative questions. So it was based on main 3 domains, like personal appearance, resemblance, and nature of the interpersonal relationship among the older population. So there was another, we used a question to assess their willingness, and it was a self-developed question by the investigators. In there, the responses to willingness of the participants were based on their agreement and disagreements with the questions. So the responses, they were it categorized like strongly agree, agree, not agree, not decided, not agree, and strongly not agree. So after achieving the consensus among the research team and based on the pre-test, minor modifications were made to the item of Coggan's attitudes of towards older people scale to ensure the readability and the cultural appropriateness. And of course, we did a pre-test with 10 nurses at UHKDU, and they were excluded from the main data collection. All the ethical considerations were performed and approved from all the relevant authorities. Then the data analysis, we used SPSS version 26 and to identify the significant relationships between categorical variables, descriptive statistics, and we used Pearson's chi-square test. The p-value less than or equal to 0.05 were considered statistically significant. Then the results. So here, the total sample consists of 267 nurses, and it indicated a response rate of 87.82%. So according to our first objective, attitudes toward older people among nurses, so we got responses only for slightly negative and slightly positive, and most of them were under the slightly negative, and it was 155 nurses, and the percentage was 58.1%. Then for the willingness, likewise, most of the nurses show a little interest, like we got not agreed to that question. The question was like if a specialized geriatric or gerontological care, that we assessed that they would like to work there. So we got not agreed. Most of them respond like not agreed. Then we assess the association between socio-demographic variables with nurses' attitudes and older people. So we used Pearson's chi-square test. So here, all the factors were significantly associated, as you can see in the table. So in previous studies as well, research done in 5 government hospitals in Ethiopia, we saw that the socio-demographic variables were significantly associated as well. Then association between socio-demographic variables with nurses' willingness to on older people. In here, except the educational level, all the other factors were significantly associated, but we got for level of education, P equals 0.072. Similar to our study in literature, we saw there was in the studies conducted in Malaysia and Western Pennsylvania, the educational background was not significant. So finally, the conclusion, according to our study, the attitudes of nurses toward older people range from slightly negative to positive, and they also seem to like a little interest, willingness in working with them. And when considering the associations, all the socio-demographic factors were significantly associated with the attitudes, and except the educational level in willingness, other factors were significantly associated. So although nurses are the primary caregivers for older people, interventions and methods are the key areas to improve their willingness to engage with older people. According to my research recommendations, it is recommended to recognize a high requirement for further development of nurses' attitudes and knowledge toward older people. And continuous professional development programs are expected to persuade the nurses and increment in the advance in all the consideration. It is recommended to conduct further studies with large samples and in different settings. These are some references I used. And I would like to extend my gratitude towards my supervisor, co-supervisor, and my co-authors and the colleagues for their amazing support. Thank you.
Thank you, Ms. Balchandra, for your presentation. Thank you for continuing in spite of bomb explosions and all that. That is the way you should work. Now the paper is open for discussion.
It's a nice presentation.
Yes.
This is regarding your questionnaire, actually. Its Cogan scale is accepted, validated scale, but regarding the willingness, you have used only one question.
Yes, ma'am.
Is it from the literature or is it?
It was a self-developed question by the investigators, madam.
Why did you decide that one question will be enough to decide the willingness? That's a major part of your research.
Because we just wanted to know whether they agreed or not agreed, like to assess their willingness regarding if there's a specialty in Sri Lanka, if they like to work. So that's why we developed.
That you asked whether they would like to work in a geriatric ward, or do they like to work with,
Yes, the question, madam, the question is about if a specialized geriatric or gerontological care, the nurses would like to work there or not.
Most of the nurses, they had negative attitudes towards working with elderly people. I would like to know what sort of attitudes they have, that these negative attitudes, because I saw your conclusion and the recommendations you propose CPD activities and attitude changing activities. So first we need to know what sort of attitudes the nurses have towards these elderly people. So what did you explore during the study?
Madam, according to the questionnaires that they answered, so for the responses, we saw they were not agreed with the all the people's decision making and under the question statements under decision making and all statements. So they were the main statements that we recognized from our study according to the questionnaire.
Okay, I have a small issue with this topic, attitudes towards the willingness to work with. I think
I also had the same issue. You know, working with this, like your colleagues.
So when I read the
fact also doesn't say whether you are talking about patients or your colleagues.
So I think the best better is to look after or care. You say attitude towards the willingness to care elderly or older people is exactly what you do as nurses, to care the people, to work with. Because I was reading this a couple of times. Just initially I thought the young nurses whether they like to work with elderly nurses or something like that. That is also there in the wards. Sometimes they don't like to be rostered with the others. No. So I think that is a thing that you should consider. The other thing is now when we train people for professions like for doctors and for nurses, we need to look after three aspects of their training. One is the knowledge. You impart knowledge and you have to give them practical skills. That is why we send them to the wards and to give every nurse should know the basic nursing procedures, practical skills, and also the attitudes. And if you know about the Bloom's taxonomy, the lecturers here know, those are the things that we do. So it is the duty of the Department of Nursing and Midwifery of the college, because because out of these nurses, if you put the breakdown, 90% of them are from our own graduates. If you say that they don't have a good attitude towards elderly care, that is the responsibility of our nursing department, no one else. So the head is here, all the members are here, and the dean is here. So this is something that you have to take up very seriously and look after these students, make sure that they are good. But I have one small thing. When you talk about attitude, now here it says attitude towards and willingness. Willingness and attitude are two different things. For example, now if you ask me whether I am willing to look after a cancer patient, because I have no expertise in the recent times looking after a cancer patient, I might say I don't like, because I like to look after heart patients. So that is the willingness. I'm sure similarly your dean might not want to look after a cardiac patient, because I know that he has not been there for a long time, but he will be very happy to look after. So that is the willingness. But attitude is, if I say, oh, cancer patients, I don't like them. If I say that, that is the attitude. So you have to differentiate this from the real attitude you have. If you see an elderly person, if you start not liking them from now, forget about the career that you are in. That is a serious issue. So we have to split hair and find out exactly what they don't like, because we all have our likeness for certain areas of the profession. So some people like nurses want to be in the theater, nursing.
When you are comparing these things, now you have taken your pediatrics, A&E and everything. Have you taken the theaters and ICUs also?
Yes, sir. All the nurses who are working in the UHK.
Okay, right. Have you categorized them whether they in that categories also? You know, they are working, say, in theater or in ops and obstetrics. They're all obstetric means always young people. You know, there are no old obstetric people. There won't be any elderly pregnant ladies. No, they are all young.
Only
Right?
very
So
rarely.
there's yeah?
Only very rarely.
Only very rarely. And the pediatric board, there are no elderly care. So why have you categorized them also in the same book?
I think what they are trying to do is take nurses as general and checking their
Attitudes and
and also I mean, if they knew that, if they don't know that this is a study, they might want, he's collecting data to give them a transfer to that ward. I don't know. So anyway, that is a very interesting study. Yeah, thank you very much. I think that's a very good suggestion. I agree with you. Thank you very much. Okay. So we'll move on to the final. Thank you, Ms. Balchandra. We'll move on to the final presentation for today. That is on anxiety and depression among field midwives in selected MOH areas in Madhya district, Sri Lanka during COVID-19 pandemic. The author and the presenter is JMP Patirana, and the co-author is AATD Amarasekara. They are from the Department of Nursing and Midwifery, University of Sri Jayawardhanapura. Over to Ms. Patirana.
Very good afternoon for all of you. And I am Jayatri Patirana. I'm from University of Sri Jayawardhanapura. And I have done my research under the supervision of Professor AATD Amarasekara. And here's my research topic. You can see anxiety and depression among field midwives in selected MOH areas in Madhya district, Sri Lanka during the COVID-19 pandemic. And here's my content, and let's have a look about the introduction part. I think you all know about COVID-19. In December 2019, there's unexpected novel pneumonia was derived in China and then spread throughout the world. So this COVID-19 outbreak affects severely for the global economy and also the population. Also, it had been severely influenced in physical and the psychological lives of people. So some studies reveal that most of the healthcare workers also affect this, and they, research studies reveal that there were symptoms of anxiety, depression, and among the healthcare workers during COVID-19. And in the Sri Lanka, the first COVID case was reported in January 2020. And from when considering from healthcare workers, field midwives are have an unprecedented challenge, as field midwives are the ones who are only in Sri Lankan context and also who provide care to mothers and children in the community. And also from with their occupation, field midwives are at risk of suffering from psychological issues. And here's my justification. In the Mathura district, there are 10,334 total COVID patients in the first outbreak, and you can see the in the second outbreak and third outbreak how they recorded, and also there are 146 deaths were reported until the date of 27th of August 2021. And also, according to the data obtained from the RDHS through the phone, there were 229 COVID-19 positive pregnant mothers also in the Mathura district. So, with this situation during the pandemic, field midwives were given their care to mothers and the children also. And when I go through some research studies about healthcare workers, about their anxiety and depression, I found that there's a positive data regarding the level of anxiety, depression among field midwives. So I chosen this study to done as my undergraduate research. So here's my objective. The general objective is to assess the level of anxiety and depression among field midwives. And the specific objectives are here. Those are to assess the level of depression and anxiety, and also to determine the associated factors for anxiety and depression among field midwives in selected MOH areas in Mathura district. And here's the methodology part. And you can see I used a this is a quantitative descriptive cross-sectional study, and I selected this study setting is randomly selected MOH divisions in Mathura district, and field midwives were also selected randomly. And as the inclusion criteria, I used 6 field midwives with 6 months of experience, and as exclusion criteria, field midwives who had not the 6 months of experience and on the maternity leave. And here's field midwives were purposely selected for my research study, and the study sample size calculation was done by the Taro-Yamane equation, and here's the sample size 157. But due to the prevailing situation, I able to collect data from 145 participants, and I used an interviewer administered questionnaire. And this questionnaire was composed with 2 validated tools and consists with 3 sections. In the section 1, it's socio-demographic data. In section 2, to assess the level of anxiety, I used GAD-7 tool. And section 3, I assessed the level of depression. And for that, I used a PHQ-9 tool. And also, descriptive statistic chi-square test was used to find variances among different associations with the use of standard statistical software version 26. And ethical approval was also obtained from the relevant authorities. And so let's have a look about the results. In my research study, 145 participants were there and response rate is 92%. From the participants, you can see the mean age of participants at 41 and with a standard deviation of 12.01, and the majority of them were married and having one or more children. And also you can see here most of them were having years of greater than 10 years of experiences. And you can see the distribution of GAD7 and PHQ9 total scores. From GAD7, the mean value is 4.88 and with a deviation of standard deviation of 4.94, and the PHQ9 from the PHQ9 it was 5.75 and with a standard deviation of 4.63. And here you can see the anxiety levels and depression levels with this graph, with this chart. And from that you can see the majority, most of the participants were suffered with minimal anxiety, while when talking about the anxiety, while 6% were suffered with severe anxiety. When talk about the depression levels, 46% were minimal or none depressed, and there were 32% were mild depressed, and others are here. So let's have a look about the factors associated for anxiety and the depression. First, you can see the the factors associated for the anxiety. Here, the age with the p-value, I used with the p-value, the age and parental status and accommodation and years of experience, history of chronic diseases, death of family members, relatives or friends due to COVID-19, and the economical status have shown the significant association with anxiety. And also when talk about the depression, the associated factors, the family type, place of residence, and history of chronic diseases, and family members, relatives, or friends infected with COVID-19 have a significant association with the depression. So let's have a look about this is discussion part. That is this is the discussion part, and here I talk about from other research studies. The majority of the participants showed minimal anxiety, that was 54.5%. In contrast to that, Egyptian study showed approximately 9.5% had not had the generalized anxiety. I think this may occur because Egyptian study was done in the acute part of the COVID-19, that means peak level of the COVID. But the present study has conducted in the later part of the COVID-19. And from that, majority of the field midwives showed none or minimal and the mild depression with the COVID-19 than the nurses in the Iran study that was done in the Iran study. And here's the and also another study, a study done in India showed about half of the healthcare workers had depression. This may happen due to the population, because India has the most population in most high population in India, and also having chronic diseases increase the probability to have depressive symptoms. The present study also showed showed history of chronic diseases associated for the depression, and also the previous studies also have shown these chronic diseases increase the to having depressive symptoms. And also Iran study showed being female was associated with anxiety and depression. As field midwives, all field midwives are females, there is a possibility to have depression and anxiety with them. And the marital status was not associated for the depression in this study, but another study showed that being single suffered with depression. Here you can see my the limitations of my our research study. The calculated sample was not achieved due to the COVID-19 pandemic situation, and as used interview administered questionnaires it also found some risky during this situation where the social distancing is much more important. And this study was done for in selected MOH areas in Mathura district, so that limits the generability. And here's the conclusion. Age between 50 to 65 and having one or more children are having severe anxiety, and greater than 10 year experiences and participants with moderate economical status experience severe anxiety. And most of the participants were mild depressed, while 55% suffered with minimal anxiety or none. And also the factors associated with anxiety were age, parental status, accommodation, years of experience, history of chronic diseases, death of family members, relatives, friends due to COVID-19 and economical status. And also factors associated for the depression are the family type, place of residence, history of chronic diseases, family members, relatives or friends infected with COVID-19. And here are my recommendations. Health policymakers can take measures to increase the psychological aspects and coping styles of field midwives. And also similar studies should be conducted for large population sample than this study by considering the geographical status, that means rural, urban or semi-rural. And also the head of the MOH can arrange counseling sessions for field midwives. And here are my references. So finally, I would like to express my gratitude to all the participants and the professionals and my colleagues who helped me in finishing this project. And thank you all.
Thank you, Patirana. That was an important topic because the COVID-19 pandemic was a very stressful situation for all the healthcare workers. So thank you for selecting that topic. Now the paper is open for discussion. Yes, sorry.
Studies you have discussed about two scales for anxiety and depression.
Yes.
How this questionnaire has been validated through Sri Lanka?
Yeah, validated.
Okay. The second question is, have you found any relationship or correlation between these anxiety scores and mean scores and depression mean scores?
In my research study, I didn't go through for those things.
Okay.
That's why.
Those are not only
No.
objectives, right? Okay.
What did you do with the people who had depression? 0.8% severe depression, some percentage of people had severe anxiety. What did you do with it?
We have to first we have to talk very friendly with them. And
my question is, when you identified them, what did you do with them?
that means
The score was that high.
and suggest for the counseling session.
Now, when you do a study and identify some abnormal, health abnormal, is high, you have to refer that patient to, because it's your duty, otherwise the study is not ethical. 2 days, 2.8%. People, they may be having suicidal ideation. They can commit suicide. depression. So severely depressed, severely anxiety patients need treatment. So as soon as you identify them, okay, you got your data, but you also have to refer them to the some place where they can be further evaluated and treated. That I agree, but if otherwise we shouldn't have used it. No? It is a screening test. It is a screening test, and to find an abnormality, you have to either confirm it or disregard it by doing further evaluation. Because next day, you find this person is dead. Evidence is so important.
I also have a question regarding associated factors for anxiety and depression. So for the instrument you have prepared, how did you select the associated factors? Through the literature or else literature from local or else from the entire global literature?
Yeah.
Did you
From-
consider
yeah.
global literature in order to develop these associated factors? So according in your this table, I saw most of the factors are demographical factors you have used, no? Most of the demographical factors actually you have used as the factors associated with anxiety and depression.
Only the highlighted ones.
Okay, did you do validity and reliability for your instrument mainly in order to find the association between associated factors between anxiety and the depression? Did you do validation and the reliability checking for your instrument?
This is a validated tool.
It is essential to do. It is essential to check the validity and reliability of your instrument for the factors.
No, didn't do it.
You have validated. Okay. Okay.
Now,
Likelihood.
Chi-square for 4 factors in 6 areas.
Sorry, sir.
Comparing 3 things together, 4 things together, you put chi-square there.
Yeah.
Okay.
Said we were administered questionnaire as a patient because you could do it or what?
To get the best results, I use interview administrator as some with the busy life, they didn't like to fill the questionnaires lonely, or they feel justly. So
you actually interview them and fill the question.
yeah.
That is good because it's not a limitation. Because what I understood was because of the COVID pandemic and social distancing that you couldn't do it. Then it is a limitation. But if you did it by taking a risk, that's a great thing. Take risks to do research. Going to the community and interview these people at that particular time was a risky thing. But it is not a limitation. You did well, right? You did great.
So that can be also a limitation, like when it's those 2 questionnaires are actually self-administered questionnaires. But when you go and interview and ask questions, that can also make a interviewer bias, and that can also alter the.
Yeah, but the original plan was to do that, and he has done it. So that is great. Okay, with that we'll conclude. Thank you very much, and let me say a few words before we conclude the session. I think it was a great session. We had 5 very good presentations, good topic selection. I must thank all the presenters for sticking to the time and also coming in person to present here. when the online facility was available for you, I mean, coming all the way from Galle and from Srijawadanapura, and also from Arts University. Thank you so much for coming here. That encourages us a lot. And actually that gives a very live atmosphere to the session. So I must thank all of you. And also selecting very good topics. Now starting with the elderly care, the institutionalized persons, it's a very important topic with time to come. And you had very good study on that. And also sexually transmitted diseases is a very important problem. Also, the youth need to be educated about it. So thank you for that. Then the role of CPR. I mean, every citizen in the country should know CPR. I mean, people just die on the ground. Colleagues, their coaches, their parents, their teachers, no one has even attempted CPR. And if not only the traffic police officers, there are important group of people who should know this, but everyone of us should know about it. Not only healthcare workers, very important topic. And the attitude towards caring elderly people, I hope you all will, Kalpani and the team will take some charge on that and inculcate good attitudes, not only to look after the elderly people, but also to look, I mean, the most important thing in patient care, most important aspect is done by the nurses, not by the doctors. Right? You are the people who really care the patient. So remember that, and that is much more important for the patient than someone coming there, examining and diagnosing and ordering the treatment. So please remember, you have to look after any sick person, not only elderly, anyone. And anxiety and depression among the midwives, field midwives, was very important topic. And also, someone should study, if you need a research topic, the ICU nurses who look after, and the ward nurses who look after the COVID patients. They were at a much higher stress level, and someone has to study that too. Now, as I always tell in this sort of forum, we ask questions and we make comments and we criticize to improve the study. Don't take it with good spirit. I can remember I have started presenting as a medical student and as a junior doctor, and I have been grilled. That is okay. I mean, that is how we have improved. So all the questions were asked with spirit and the comments were made, and that is how we have to do this scientific sessions. And some learning points we have time to tell with all the presenters, like making slides. Now, example, some font sizes are very small. So you have to pay special attention because you're competing here, and also you are trying to give your research findings to others. So they have to be very attractive. Don't put small letters. Put some nice diagrams and attract the people towards your presentation. And the other important thing is, when you present, it's a great thing to present, right? I mean, you have, we heard yesterday more than 600 abstracts were submitted and only few were selected. So you are among the best already. But when you present here, it doesn't stop there. A lot of people don't transform it to a publication. So we have to write it up now. Right? Now, presenting is important to identify the shortcomings of your study. You can address that in your publication. Now, all the criticisms we made should be taken with both hands and address them in your write-up and make it a good publication. Some people satisfy there. Oh, I went to the KAATSU and presented this in the conference. That is not enough. You have to publish it and make it a good publication in a peer-reviewed journal. Okay. So those are the important things I want to tell you. And also, this gives you a lot of experience in when presenting in even other bigger conferences, like international conferences. And usually your supervisors don't come with you. You are the person who can present. And this gives you a lot of experience. Right? And also, this will be helpful in your higher studies. All the presenters were relatively junior colleagues, and I wish you very well your best to pursue higher studies and be the top in the selected field. Thank you very much. And do we have anything to say? That concludes the session. And thank you again for inviting me. And I also really enjoyed and thanking the Dean of the Faculty and the head of the Nursing and the Midwifery Department and the rest of the academics there. Thank you.
Ladies and gentlemen, we have now come to the end of the technical session 2 of Nursing and Midwifery. Before concluding the session, I would like to invite the chairperson, Professor R.A.N.K. Wijesinghe, Professor of Medicine, Dean, Faculty of Medicine, General Sir John Kotelawala Defence University, to award the certificates to the presenters as a token of appreciation. Miss M.L.P. Rasangi. Miss M.F.F. Fasmila. Miss R.T. Balachandra. Miss J.M.P. Patirana. Thank you, sir, and please remain on the stage to present the mementos to the panel of judges as a token of appreciation. First, I humbly invite Dr. Ranga Pereira, Senior Lecturer and Dean Faculty of Allied Health Sciences, General Sir John Kotelawala Defence University. Next, I humbly invite Dr. S.M.K.S. Senivirathne, Senior Lecturer, Department of Nursing and Midwifery, Faculty of Allied Health Sciences, University of Sri Jayawardhanapura. Next, I humbly invite Dr. M.P.K.W. Wijesinghe, Senior Lecturer, Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Sir John Kotelawala Defence University. Thank you, sir. Could you please remain? I would like to invite Surgeon Captain Dr. Ranga Pereira, the Dean, Faculty of Allied Health Sciences, to present the memento as a token of appreciation to the chairperson of this session, Professor R.A.N.K. Wijesinghe, Professor of Medicine, Dean, Faculty of Medicine, General Sir John Kotelawala Defence University. Thank you, sir. On behalf of the organizing committee, I would like to express my sincere thanks to the chairperson for his invaluable participation and cooperation. Also, I would like to forward our gratitude to the panel of judges and all the presenters who presented their interesting research work to make the session a success. Just as importantly, I would like to thank the audience for your participation and encouragement for this session. With that, we conclude the technical session 2 of Nursing and Midwifery 15th International Research Conference of General Sir John Kotelawala Defence University 2022. I would like to make a small announcement before winding up the session. I would like to invite to enjoy the lunch, which have been arranged for the chairperson and the judges at the officers' men's, and for the presenters at the please remain here. Also, I would like to remind you that our next technical session on nursing and midwifery will commence at 1 p.m. So, thank you and have a nice day.